I think one of the things that we learned very early on was that you can turn students off if you don't prepare them properly. And it seemed very relevant with that you needed an adequate didactic base for the students and a comfort with clinical procedures before you sent them into an environment where they were dealing with at-risk older people. So until they were technically competent and not worrying about doing the technical thing, but then could interact with the patient and understand the issues, it was a stress level which they couldn't cope with to do that. And therefore, I think in the earlier years that they get experience with healthy older adults or relatively functional, independent older adults whose medical issues don't compromise their care. And when they're comfortable with that, then they can move on to the frail and functionally dependent. And that's in their senior year. So to expose them earlier, I think has been shown in several studies to create a negative experience. And all of us don't like to be uncomfortable. And if you put people in an uncomfortable situation, they're not going to do it. And if they won't do it as a student, they're certainly not going to do it when they're in practice and can choose who they're going to see and what they're going to do. I think the model that we develop and which we feel comfortable with is based more on the medical model, in that students aren't there all the time, and therefore the patients are assigned to a faculty member and they relate to that faculty member. And then you don't have the situation of a patient coming in and somebody coming up and saying, well, you know, what's the treatment plan? Oh, I don't like that, let's change it, kind of thing. There's a continuity, and there's a rapport that develops between the patient and the faculty member. It doesn't matter to them that the students are changing who are doing their actual care, although the students do develop a daily relationship with that patient. They feel that they're your patient and that they can relate to you. And I think that's important with these patients. Because one of the reasons we developed the special care clinic was that we saw patients that came to the school once and never came back again. Because they just simply couldn't cope with going to this department for that, and that department for there, and this department for there. So, and it wasn't based on age, it was based on frailty. And therefore, the special care clinic dealt with people who were physically frail, mentally frail, and had a number of complex medical issues, who felt that, you know, we could get them in and get them out and get them cared for in a specific setting. And I think that certainly helps. With the residents, the thing that we were able to do in terms of credibility was that we had them be part of the geriatric assessment clinic, where new patients were coming in, and they, like all the other disciplines, added their component evaluation to the team to develop the treatment plan. And they also participated in nursing home rounds with the geriatric fellows, medical fellows, and could add drug reaction, oral effects from the drug reactions and stuff into what was going on. And so they were educating and getting credibility because they were adding information which was not available to the group. Yes, and they do, because these are the majority of many patients in many clinics, from perio to to PROS, to,
So the well elderly.
The well elderly or functionally independent go to those clinics. That doesn't mean they don't have some chronic disease. I mean, in terms of hypertension or diabetes or something of that sort. And the students are required to take an adequate history, and they just about routinely, it's been drummed into them, they don't even think about it, to take a blood pressure for the patients. They're quite competent at doing that and do it automatically now, and hopefully they will carry that on when they go into practice. The essential problem is recruitment. And if we're going to be able to recruit people, it has to have some kind of reward, either a financial reward or a status reward. And at the moment it has neither. One way to do the status reward would be a form of specialization and recognition by professional dentistry in terms of the dental schools, the hospitals and so on. And hopefully a change in the structure of how people are reimbursed within the dental care system, so that this expertise is recognized and rewarded at a higher level.